Hello. Hi, everyone. So the people who are talking the loudest are seated next to me. Hi, Bo. Hi, Anshu. Good to see you. Ladies and gentlemen, really nice to see you. And thank you so much for sparing your time to be with us this evening. Our third Lives in the Balance event on the sidelines of the World Health Assembly. I mean, PMNCH and our PMNCH colleagues, we should give ourselves a round of applause. It's been amazing, right? So thank you so much for being here today. And I hope everything that you've been doing has been successful. And I said the first day that we meet, for everybody who was in our first Lives in the Balance event a few days back on Sunday, I say that we have come to a fueling station, and this is our last fueling station when it comes to PMNCH events. So I hope you have enough fuel to take the conversations forward. So the next 2 hours, 1 hour will be a bit serious deliberations, listening to people, and then the next hour will be a lot of fun because we just don't work, we work and play a bit, right? Okay, now, my name is Masi Juma, and I will be your moderator for this event. I work with the BBC, but when I am not doing journalism, I am an active advocate for maternal, newborn, and child health, and that's why I'm here today. Now, before I invite our opening speaker, let me give you some data or statistics. So every day, 800 women die from complications of either pregnancy or childbirth. And these are preventable causes. Now, I want us to do some math. 800 women every day means 33 women every hour. Now, we'll be here for 2 hours, and within those 2 hours, 66 women would have died somewhere because of something that can be prevented. I'll let that sink in. It's unacceptable. We have been talking about preterm births, and the videos we have been watching here are about babies born too soon or babies born preterm. For the last 10 years, none of our countries, all of us who are here, none of our countries, none of our regions has had any change on the rate of preterm births. We have all flatlined for 10 years, 10 good years, the rate of preterm births have remained the same. We will hold another conference, we will talk about it, we will make campaigns. The next WHA, are we going to talk about the same things? I will ask again, the next WHA, are we still going to talk about the same things and the same numbers? No. You guys have no hope. Are we going to talk about the same numbers in the next WHA? No. Thank you. And that's why we're here. That's why we're holding these discussions, right? So, ladies and gentlemen, in the next hour, we will hear from presenters and panelists about their efforts to strengthen systems, because that's what we want, and improve coverage and quality essentials interventions in health services, and most important, to reach those mothers and newborns and children that are the most vulnerable. We are talking about, mothers like the ones who are in Sudan today. And if you have had me the last 2 sessions that we have had, you've heard me talk about Sudan a lot. Anybody from Sudan here? No one. No one from Sudan here. Yet Sudan has entered its 6th week of fighting. Women are dying, children are dying, women are giving birth in the back of trucks, children do not have essential care, women do not have sanitary towels, everybody is rushing to take in, food and everything. Nobody is talking about the dignity of these women. We should be ashamed of ourselves. It should be a wake-up call. And I hope in our individual capacities, ladies and gentlemen, we are going to make a change as individuals, as organizations, as countries, as governments, as donors. It's a movement, it's not a moment. We have work to do. Our first speaker, welcome remarks from Anshu Banerjee from the WHO. Anshu, the floor is yours.
Thank you very much, Mercy. And I hope people have been listening to the World Health Assembly, because in fact we had the progress report for the global strategy on women, children, and adolescent health presented, and highlighting a number of the statistics that Mercy was just highlighting. But we had around maybe almost 100 member states who actually intervened and who made interventions on what they thought were their priorities, their achievements, but also highlighting why they are having issues and what their problems are. And I must say that we're very lucky that also member states asked for a resolution, Mercy, to highlight what's going to happen next year at the World Health Assembly, a resolution to address stagnation of progress towards women, children, adolescents' health. So I think we do have opportunities where we bring member states together. We'll have an opportunity to discuss with member states what they think is important and what kind of targets they want to set for themselves in order to achieve the Sustainable Development Goals by 2030. So over the last few weeks, months maybe, but let's say weeks, we had a lot of attention towards maternal, newborn, child, adolescent health. We had the international conference in Cape Town 2 weeks ago, looking specifically at maternal newborn health. We had over 1,800 people who were there, but we had 30 country delegations who were there and who had a day afterwards, after the conference, to start thinking and planning on how they want to take this agenda item forward, how they're going to develop acceleration plans for maternal newborn health. And of course, we don't want to stop there. We know that besides the stagnation we have had in preterm birth and in maternal mortality, we still have a huge mortality agenda around child health and looking at mortality due to diarrhea, pneumonia, and also malaria, preventable causes that either could be prevented through immunization. And we heard also during the assembly issues, and we'll hear more about that, around the malaria vaccine that should be scaled up in order to address mortality due to malaria. But of course, we have still a number of countries that can scale up pneumococcal vaccine, rotavirus vaccine, etc. So huge opportunities there for countries to step in, step up, and address preventable mortality. During the conference, though, we had a launch of a couple of landmark reports. We had a Lancet series on small and vulnerable newborns. We had the Born Too Soon report that was led by IMNHC. We had the INAP-EPMM joint progress report, the first one we did. And those reports were, of course, highlighting the dramatic statistics that we are in at the moment and highlighting all those mortality rates, etc. But also don't want to forget the stillborn agenda, and that, you know, when we're looking at what countries are targeting, many of them are looking at newborn mortality, making plans for that, but many fewer, is that correct English? I don't know, but we're looking at addressing stillbirth rates and how to take that forward. So I hope that, and unfortunately also during the Sustainable Development Goals discussions, we were not able to put a stillbirth mortality target in there, and I hope that with our resolution next year, we'll be able to put in a stillbirth mortality target. A personal aspiration, but of course will depend on member states. But I just wanted to take a poll, because I'm sure that all of you have read the INAP-EPMM progress report, and you are all aware of the targets that we have set for countries to achieve the SDGs through implementing a newborn action plans and ending preventable mortality. So I'd just like to hear from you what those targets are. Does anyone here 90, 90, 80, 80 ever in their life? Boo, you said yes?
Yes.
Yes. What is it?
Yeah. It's 90% access and 80% high quality, something like that. Yeah.
Okay. So the 1990-80-80 goals are joint goals for INEP and EPMM. 90% antenatal care. That's the coverage that we want countries to achieve. We're looking at 90% skilled birth attendance. We're looking at 80% postnatal care because we know we're a bit behind there. And we want that 90% of districts have a special care unit for the small and sick newborn. But we didn't stop at that with those targets. We're copycats a little bit, from our immunization colleagues, and we ensured that there is a subnational target linked to that. And so it is not only a national target for 90-90-80-80, but they reflect also subnational targets. And why is that important? And that's because of equity. So I'll come to the equity in a minute, and I'm sorry, Mercy, I know I had 2 minutes, but I'm going to go way over. But looking at maternal newborn health, but I just highlighted, of course, also the fact that we still have 1.5 million children dying because of pneumonia, diarrhea, and malaria, and what are we going to do there? So we have, as part of the Child Health Task Force, developed the Child Survival Acceleration Initiative. Let me call it an initiative. And we're going to, just like INEP and EPMM, look at targets that we want to set to support countries in achieving those preventable mortality targets for child health. But of course, the figures that we have seen hide inequities, and we have inequities between countries, unacceptable ones, like Mercy said, but also within countries. And I think one of the issues that we really wanted to make sure is that countries start thinking of their in-country, intra-country inequities and how to address that. And that's why with INEP, EPMM, we set those subnational targets so that countries, when they go and look at the data coming from their routine health information systems, can see what the inequities are between districts, regions, provinces, whatever it's called in the country, and how they then need to invest in order to address those inequities. And so, I mean, we don't only applaud the approach that our immunization colleagues are doing around zero-dose children, but we feel that that concept needs to be broadened out. And WHO, together with partners, UNICEF, UNFPA, but also some of the funds, etc., we're now together developing a tool to address micro-planning at the district level that is going to take an approach of identifying the vulnerable households. Because we feel that by being able to identify the vulnerable households, we'll identify the zero-dose children, we'll identify those mothers who have malnutrition, the children who have malnutrition, where there are no wash facilities in the household as contributing risk factors to mortality and decline in well-being and development, etc. We've come up with a couple of other sets of guidance documents. Our stage came out with a position paper on kangaroo mother care and on a guidance note on how to take that forward, major interventions that we can really now scale up at subnational level, including ensuring that every newborn child who's small or sick, even before they have been stabilized, and even if they're born in the community, can benefit from kangaroo mother care. We have started looking at, well, we had last year, we launched the Preterm guidelines. I think that got a lot of attention, but I just wanted to highlight and want to give everyone a sneak preview that in a couple of weeks, we'll also have the first progress report on nurturing care and the nurturing care framework. Very essential, I think, for those children who are born to achieve their progress, their well-being, their development, and how we do that through a multi-sectoral approach. So, and that report is going to highlight that we have had a scale up of 50% to almost 100 countries now who have developed either early child development or nurturing care framework policies or national action plans. So a step forward. And then maybe just to come to implementation, we've been working with UNICEF and WHO on the well child approach. and that has been discussed. We're coming out soon with a document that is going to highlight how to implement the well-child approach from 0 to 19 years, linking it up to visits that we think are essential from 0 to 19 years. And we'll also, and the other thing to implementation, of course, and that is going to be crucial. And I think Bruce, in his closing comments today during the agenda item on the progress report for women, children, adolescent health, said that we need to focus our attention within universal health coverage and primary healthcare towards the goals that we have set out to deliver. And those are 3.1 and 3.2, maternal mortality and child mortality reduction. Thank you very much. And next.
Anshu, you'll probably pay for these. Those were 10 minutes. Was anybody counting? So I am not accepting any other apologies, ladies and gentlemen, because like I always say, we don't want the people who are holding the wine glasses and the juice glasses and the water glasses to wait for us for so long, right? Yes. All right. Bo Jacobson from FIGO, the floor is yours.
Hello, everyone. I'm here to do a little bit of introduction to the Born Too Soon report video that we're going to see, and a little bit as a background. Globally, there is a combined 4.5 million maternal and newborn deaths and stillbirths every year. That means we have heard a little bit of the statistics from Mercy here before, but it means that there is one death every 7 seconds. And if we do not change course, we stand to lose more than 30 million women and babies by 2030. 30 million. And more than half of them will be in sub-Saharan Africa. An estimate of, in the Born Too Soon report, 13.4 million babies were born preterm in 2020, with nearly 1 million dying from preterm complication. That means that 1 in 10 babies are born too soon or born preterm. And preterm has been long under-recognized, both in scale and severity, with impending progress in prevention of preterm birth and improving childbirth and health and survival. So we need more preterm prevention and more improvement of children's health and survival. So PMCH, together with WHO, UNICEF and UNFPA, 2 weeks ago, launched the Born Too Soon report in Cape Town. And I'm pleased to invite you to watch a brief video about the critical movement to support the prevention of preterm birth and care of preterm babies as a fundamental component of high quality integrated care for women and babies everywhere. Fundamental component of high quality integrated care of women and babies everywhere. Thank you.
Every 2 seconds, a baby is born too soon.
He was so tiny, covered in tubes.
It was a dark time. Are they breathing? Are they alive?
In richer countries, 9 in 10 will survive. In poorer countries, 9 in 10 will die.
I was not allowed to touch him. I felt so powerless.
I thought I might die. She might die. It was stressful.
The world's most vulnerable face a worsening storm of conflict, climate change, COVID-19, and a cost of living crisis. Together, we can protect them. In 2012, the first Born Too Soon report was a catalyst for change. With new targets, strategies, innovations, and respect for rights, we know what works.
She is my ray of sunshine. I focus on her survival.
He is the sweetest boy. We enjoy every milestone, his every laugh.
He has amazed us. He has survived and thrived.
70 organizations from 45 countries, backed by parent power, are calling for investment and implementation of high-quality, respectful care for every woman and baby, everywhere. Born Too Soon, a decade of action on preterm birth.
Yes, so an executive summary of the Born Too Soon report is on your seats. Please feel free to indulge. And the report is also live at Mihail, www.borntoosoon. Yes, there's a QR code on the back, so please go. This is our preterm birth Bible. You have everything in there. So ladies and gentlemen, please utilize that report. And I hope it's not just going to sit in our computer downloads and in our shelves in our offices. Let's utilize it. Joy Pumafi, the floor is yours. You're welcome.
Thank you very much. Distinguished guests and friends, I want to share with you a little story about a young girl called Botu. Botu comes from one of the 10 countries that you have heard about, which account for 60% of global maternal deaths, stillbirths and newborn deaths. She is extremely happy to be pregnant because she is envisaging a situation where she can celebrate life as she's giving life. But she's also the most traumatized she has ever been in her life, because she knows that her baby might be one of those that are born 2 seconds too soon, or one of those who are going to lose their lives 40 seconds, every 40 seconds. She knows that she might be one of the women who are 130 times more likely to die because she's in a low-income country. She knows that these are not the only challenges that she faces. That even if she survives the pregnancy, the child survives, the likelihood of them continuing to live in a malaria endemic country that is one of the 10 with the highest incidence of maternal deaths, stillborns and newborn deaths, her chances are very slim. So the likelihood is that Botu is one of the 30 million statistics that we have been told about today, and so is her baby. This is the likelihood. For them, pregnancy is not a celebration of life. For them, even if they were to live, the 4 C's that we have heard about, COVID, climate change, cost of living, conflict, have complicated issues so much that their governments, 77%, they are part of the 77% of sub-Saharan countries that have decreased budget allocations to maternal and newborn health. Chances of survival are slimmer for them than the way in 2015, when we were celebrating the end of the MDGs and looking forward to actually making double that progress during the SDG period. And we're already halfway through the SDGs. It's a defining moment for us as partners to Botu and her baby, and all the other Botus and babies, the 30 million of them. Huge inequities still exist between countries, within countries, across borders, and pose a threat to all our Botus and their babies. We have 7 years to reach these targets that we have set, which we had hoped to reach in 15 years. Progress is reliant on your bold support, your bold investment, your bold commitment. Every single partner in this room and those outside the room, under the leadership of the PMNCH PEC Standing Committee, which coordinates your response at country level. You have agreed that we develop a revised approach to the commitments mobilization that strengthens and fosters an in-country approach. So PMNCH is establishing a multi-stakeholder platform in priority low middle income countries where the need is greatest. These platforms will enable you, the partners, to mobilize, amplify, and follow up existing commitments by countries, including mobilizing new commitments, new resources for adolescents' well-being where needed, and for these 30 million mothers and babies whom we are about to lose. Through this country-focused, partner-centric approach for advocacy and accountability, our goal, your goal, is through partnership to ensure the necessary momentum is galvanized and that we do make progress. Like our MC says, Messi says, next year, let us not sing the same song. Let's sing a song of progress. The time to act is now. Messi has told us already, Boto, her baby, and the other 30 million cannot wait. Thank you.
Thank you very much, Joy. Just a reminder that, behind all the data, all the statistics we're talking about here, there's a face. It's not just numbers, like it's people, it's babies, it's families. There's a face, there's a name behind all these statistics. All right, just one more speech, and it is our keynote speech. And then we move to a panel. Please help me welcome on stage Shri Gopala Krishnan. The floor is yours, sir. Thank you very much.
Good evening. I work in the health ministry in India, and on the topic here, I don't think there can be any disagreement about all the deaths which can be avoided, need to be avoided, and but it's all a question of, like most public goods, who takes the lead, who takes the responsibility, and how do we reach there. But in respect of what has happened over the past decade, as made out in the report, one thing which is amply clear is there has been a lot of diversity in what's happening even within geographies. Now, there's no fun in claiming that, okay, we have done well, etc. Even in a country of the size of India, there is huge diversity. Some places have done very well, some places have not done much so well. So the message for us also is to see what has worked and ensure that you can take that to every other place. So such being the case, our approach in trying to reduce such deaths is that we need to have the systems in place, and one advantage is you can get technology in place. So I would just like to allude to 2-3 small interventions over the past years which has helped in bringing down unnecessary deaths. One point which is, of course, most of you are already aware of is the ASHA worker, the local health worker who is in the community, from the community, who can relate to the community and sort of keep track about who are all antenatal care. So that's one thing. The other thing is, okay, how does she or others in the health system go about doing their work? So that's where we look at 2 significant developments. One is there is a existing, I'll call it a tech platform called eWin, which is related to the whole vaccination story. Now, that is something which just talks about cold chain, logistics, availability of vaccine, etc. But the other thing which we learned during the COVID period is called the CoWIN platform, which is more about almost the whole population being there, individuals, their COVID vaccination, track record, etc. Now, a marriage of the existing eWin and the CoWIN is what we are talking about, like the prospective UWIN. So which has the track record of antenatal care and vaccination of the whole eligible population. So unlike the earlier scheme when things were in digital, you were possibly shooting in the dark. We had no clarity about who may be missed. But right now you have a line listing, and your ASHA worker and others are able to keep track of who needs to be taken care of, whether they reach the right facility at the right time, etc., so that deaths can be avoided. So these have paid fruits in respect of the numbers which we see in certain states. And that's where I'd like to revert to what the MC also said about In certain geographies, in certain countries, women are dying, etc. But the point is, healthcare or preventing such deaths is just one aspect of the whole governance machinery. So even in India, among the states, if these differences are there, it is also partly attributable to the way the machinery is working, including in the health machinery. So for which the only way out is to go for greater advocacy and make the investments. There should be a political will to make the investments in respect of facilities, manpower, etc., and give the relevant support. In certain places, if such support is not there, it is seen in the numbers. In certain places, because ultimately it's a question of instilling confidence in the people to look forward to the appropriate support services at these facilities and then making them available on time. The reliability, the dependability comes in once you have a system which is functioning, which is there to see, which is there with the rightly staffed people and which can provide. So I think that is the moral of the story for us internally also, as we see the figures from the states. And it is definitely shameful, even if the number goes down to even an insignificant decimal fraction, as long as it is, even if it's one life which can be avoided, and if you don't avoid, it's a matter of shame, and there's nothing to be happy about that. But the trajectory is improving, and I think there is a need for ensuring that there is greater awareness and then advocacy, because right now, at least these days, we can say that it is within reach in terms of either the understanding of the processes or the technology to ensure that we all work together to reduce it. And I hope next year at least we may be raising this topic, but possibly with better numbers. Thank you.
Thank you very much, sir. Now, ladies and gentlemen, we are moving into a very interesting session. It's a dialogue. And I can see the people who are supposed to sit here already smiling at me. You don't know what you are coming into, but it's fine. And what amazes me about this panel is that almost half of them, a good number of them, are people who I have sat in a panel with online. So we've not met in person, and we've done 4 virtual Lives in the Balance Summit. And this has been the first in-person event. So it's such a beautiful honor to invite on the hot seat, John Mangwiro, the Deputy Minister of Health and Childcare in Zim. You're welcome, sir. There's a mic somewhere with your name. Good stuff, yes. And then Martin Chungong from the IPU, you are welcome. And then Michelle Sumilas from USAID. Thank you, ma'am. Priya, Health Set Go. And lastly, Naoko Kozuki, who's the Director of Research and Innovation for SRHMNH at IRC. You're welcome. How are you feeling? Great, great, good, good. It's good that you sit next to me. All right, so we talked a lot. Can you hear me? Is this working? No? I'll grab the other one. Can you hear me? Oh, good stuff. Yes, so we have talked a lot about investment, about money. We have talked about the need for better healthcare. We have talked about legislation. We have talked about what we can do, you know, as founders, and in our individual capacity in our organizations to better maternal, newborn, and child health. And that's what we are going to talk about in the next few minutes. And I will start with you, John. You know, take us to Zimbabwe and tell us how your country is taking steps to provide just good service delivery and in all settings to ensure they are comprehensive, accessible, and most important, people-centered. So take us to Zimbabwe.
Are you hearing me?
Yes.
Right, thank you. Very interesting having you make us talk. You know, I was quite impressed when you started talking about Sudan. And I also heard the last speaker say most of the problems will be in sub-Saharan Africa, where I come from. So to me and to the country, health financing is at the core of everything. This will help us travel towards universal health coverage. And we are definitely moving towards self-defined, and the average coverage of essential services based on tracer interventions, which include reproductive, maternal, newborn, and child health, among others, within the general and the most disadvantaged population. For most countries, this is just between 30 and 15% in the African region. That's bad. Then maternal and perinatal mortality will not be reduced if we ignore the importance of health financing on improving effective coverage with essential reproductive, maternal, newborn, and child health services. The most important health financing reform is towards a deliberate increase in the availability of domestic and public funding of services in general, and of maternal, neonatal, and child health as a policy. In Zimbabwe, examples of such reforms are the mobile airtime levy, targeted health projects and infrastructure support with every budget cycle, and the ring fencing of budgetary allocations towards procurement of family planning commodities. Since 2016, public finance management in Zimbabwe has transitioned from input budgeting to a systematic program-based budgeting architecture. The Ministry of Health and Child Care has been implementing program-based budgeting since 2016. At the core of the program-based budgeting is the desire to improve expenditure prioritization, linking priorities to performance. A well-designed and executed program-based budget channels limited funding to proven efficacious and beneficial programs, leading to value for money and meeting of community needs. The temptation to copy and paste solutions from anywhere is very strong. This just shows the importance and need for locally driven or derived solutions that are fit for purpose and context. In Zimbabwe, for all you know, we have problems like sanctions against us, which were illegal. So this really helped us think outside the box and say locally driven solutions are much better than copying and pasting. So as mentioned, sub-Saharan Africa, and as you mentioned, Sudan, definitely we need to approach this differently. Service delivery of the maternal, neonatal, and child health has its own challenges that have worsened since 2019 when COVID-19 started. Firstly, human resources for health shortages due to skills flight has been unprecedented. We acknowledge the low-income countries will struggle to plug off staff exodus for richer markets. The government of Zimbabwe conducted a comprehensive analysis of the country's health labor market that started in 2022. The analysis sought to interrogate factors that derive the country's capacity to expand and retain its health workforce. The results are now guiding the articulation of National Human Resources for Health Strategic Plan. The new Human Resource for Health will be costed to produce the Human Resources for Health investment case, which will produce the Human Resources Health Compact. This compact will become resource mobilization tool through which stakeholders contribute to implementation of the new Human Resources for Health strategy. This is the product of collaboration between government and stakeholders, including World Health Organization, the Global Fund, Global Financing Facility, and the World Bank. The majority of the maternal neonatal health services are offered in primary clinics. Zimbabwe has a vision to go below rural health centers and establish village health posts. Further, community health workers will eventually be integrated into the regular health service. This will bring domiciliary services in maternal nutrition, postnatal monitoring, and nutrition monitoring closer to communities.
Honorable Minister, allow me to pause you there, because you raised a point that I just don't want to disappear, and this is where I want to bring Martin in. You talked about COVID-19, which has been a big challenge, for all of us, and a big challenge in sub-Saharan Africa. And I want us to marry COVID-19 and the critical role of legislation and how parliaments can really change. It taught us a lot, but we've talked about budgeting and accountability roles of parliament. And Martin, this is where I want you to come in. Like, how do we ensure that the same parliaments, based on the lessons from COVID-19, build a bridge between evidence and legislation and ensure that domestic resources, because again, John talked about localization of, the solutions that we're talking about, and ensure that domestic resources reach every woman and every child, including through PHC, which he has mentioned as well.
Thank you. Thank you. Can you hear me?
Yes.
Yeah. Thank you very much, Mercy. So you're for real, because
yeah, I'm for real.
we have seen each other on
online,
say television, right? Because a computer screen has become a television screen. Very good. Thank you for inviting me to this panel. I think that we have to be very clear that parliamentary action is not an option. It's mandatory, because in every constitution, it is ordained that parliaments have to make laws, they have to hold government accountable, they have to allocate resources. And so the first point we want to make is that parliaments must be willing to wield those powers that are ordained by their constitution. And it's very clear for me. So the thing is, now, how do they wield those powers? They need the political commitment. Mercy, you talked about, in your introductory remarks here, you talked about systems, you talked about a movement. And a movement is not something that is done in an isolated fashion by one stakeholder. It is something that involves a whole range of stakeholders. And for us in the Interparliamentary Union, we see parliaments as part of an ecosystem, a governance ecosystem involving a host of stakeholders. Parliaments cannot legislate just as parliaments. They have to take into account inputs and from other stakeholders. And the point we make is that evidence often does not lie. Evidence is not political in nature. It is objective. And where you cannot base your laws on evidence, then those laws cannot be effective. They cannot be representative of all of society. And parliaments do have that obligation to be the mirror of society and therefore legislate for everyone in society, especially the marginalized, like the populations we're talking about tonight, mothers, newborn, and adolescents. And so it is important. The theory is that what people don't know, what a parliamentarian doesn't know, he or she is not going to legislate on. He is not going to allocate resources. And how do we do this? It is by having the dialogues that we're having here, bringing together a variety of stakeholders, especially the scientific and technical community, to provide us with the overall, the global picture, the statistics that are very shocking. They need to shock us into action. And so it is very important that the dialogue we have here involve members of parliament so that they know what the global picture is, the forest looks like, but it's even more important for them to go back to the grassroots, to their countries, and base themselves on the national evidence, moving from the forest to the trees to make sure that the trees are in good health or in bad health and legislating. That's why it is also important that Parliament be able to rely on the data, the evidence being produced by a variety of stakeholders that are present here. That is why it's important, and we do encourage parliaments and their parliamentary committees on health to engage in country-level dialogues with the stakeholders in order to get the right information, the objective data which they can use to legislate, to hold government to account on, and provide resources. So for us, it's very important. But I also think that parliaments need and must establish their own independent source of data and evidence. Because a lot of times what the government, sorry, John, what the government provides to parliament may be politically tainted. And so you need an independent source of data that would allow you to legislate and hold government to account in a very objective, non-political manner. And I think that we are on safe ground here because what we're talking about is not controversial or political in nature. The only politics in this is that you're going to cater for marginalized populations at the grassroots, and that can bring you votes as a member of parliament. So you're doing two things, shooting two birds with one stone. You're helping to improve upon the well-being of your constituents, and then you can, in the process, get their goodwill. And last point I want to make is that there is concrete evidence out there that it is important for parliamentarians to be the representatives of their people. They live with the people every day. Honorable Minister, you may be a member of parliament because in the English-speaking Westminster system, you can be a minister but remain a member of parliament. So you know what your constituents are facing and willing to do, and you bring this to the national level. Parliamentarians even have more of that responsibility to actually engage in conversations at national level and bring those conversations, at the local level, and bring those conversations to the national policy level. And in Kenya, you come from Kenya, Mercy, and I understand that there is a bill now before Parliament to decentralize the management and legislation on healthcare access, that now the counties are going to be given more responsibility. So the county representatives are going to be able now to have a say, given that they live with those people on a day-to-day basis. And so that you have those different levels of interaction that we need to foster. And that is what the IPU is all about. And Helga, you remember that we're taking this debate to IPU assemblies to make sure that there is constant interaction between the policymakers that are parliamentarians and those who produce information evidence on the various issues that are on the ground. And so this interaction has to take place. Again, as I said, data doesn't lie, evidence doesn't lie. It is not political in nature, except you want to politicize it. Thank you.
Thank you very much. And one of the people who, or one person from organizations that are coming out with these resources and data is seated right next to you, Michelle. So automatically the next question falls on you. The USAID has just released a new framework for preventing child and maternal deaths. Could you tell us more about this new strategy and just how it recommits to the targets? Because like we have had, we're off track, how it recommits to the targets and why it's a very vital resources, for parliaments and, organizations and each one of us here.
Thank you, Mercy, so much for the question. And thanks to my colleagues on the panel. I'm so honored to be here with all of you. I want to also start by thanking the partnership for all of their work. USAID has been honored to be a partner of the partnership since its founding. And we find it to be a really important advocate for women, children, newborns, adolescents everywhere. So thank you, Helga, and your team for everything that you're doing. I want to just start by saying that maternal and child health, neonatal health, adolescent health has been a priority for USAID for over 60 years. And we believe that no child, no mother should have a less chance of surviving based on where they were born, based on their ethnicity, based on their income level, based on where they're living. We believe that everyone should have an opportunity to have the same statistics that developed countries have. And so we are working very carefully to make sure that we continue to prioritize this, that we continue to innovate on these issues, and we continue to be a leader on these issues among our donor community. I want to say that it is the truth that even before the pandemic really started to have an impact on maternal, child, newborn statistics, we were showing signs of slowing. We were showing signs of not prioritizing these communities, and we were seeing signs of resources being diverted. And then further, things happened as the COVID pandemic happened in terms of taking resources from this important community. And so USAID over the years has had many different strategies. We've had many taglines, but just recently we have re-looked at our strategy and we changed it. And we have a new framework for preventing child and maternal deaths, which strategically tries to seek measurable improvement of health outcomes. And we are very clear that we must do a couple things. We must work very carefully with our national countries, the countries in which we're working, the national governments, the local governments, and local communities to reach the goals that they set themselves. We need to understand what their priorities are, and we need to be focusing on those. So the framework has several different components. First of all, we are very focused on bringing primary health services closer to the communities and the families who need them. And we know that these systems must be integrated into a primary healthcare system to improve outcomes, improve equity, and have better cost efficiency. Further, we know that they need to be done through smartly integrated programs where all of our providers can optimize resources. That has not always been a priority of USAID, and we are working very carefully to make that happen. We're making sure that when we support clinics, we support governments, new mothers can receive counseling about prenatal care, about breastfeeding, their children can receive immunizations, those same women can receive family planning services. We provide services to protect people from malaria, diarrhea, pneumonia. We're trying to do this in an integrated fashion, and we understand that mothers, parents do not have time to go to many different services. We're working with governments to make that possible. We're also trying to reach communities where they live. This is the last mile idea, that we cannot only work in easy areas, urban areas, we need to be in rural communities. And our focus in that sphere is to work with local partners. We've been doing this over the years, but we have a new commitment to locally led development and to fund local partners where they are with what they need in a way that is easy to receive. We're working also to really work with local partners who are trusted by their communities. They're either led by women, led by indigenous communities, led by providers that people trust, so that their families are reached and they can receive services they need. And finally, we're very focused on high quality care. It can't just be care. It can't be care that is not provided with respect, with intention, and with care. And it must be quality so that people come back. Finally, I just want to say this is a commitment not just of the agency at a as an organizational priority. It is actually a priority of our administrator, Samantha Power, who just last month released this framework in a very public setting and recommitted the agency to primary health care. And as she said, we have everything we need to end preventable maternal and child deaths. We must do it together. So I would just call on all of us to take, I think, as Mercy, you said, not just statistics, not just these numbers, but to take action. Thank you.
Thank you very much. And you say, thank you, Michelle. So you say we have to do this in partnership. We cannot do this in silos. We have to work together. So it just makes sense that in this panel, we must have a young person, because 1.8 billion young people in the world today, the largest cohort we will ever have. And the solutions they're coming up with, the things they're talking about, the things that they're passionate about, are definitely what is going to shape the future. It's going to shape our future. Priya, you have done an amazing job as a young entrepreneur, just, leading healthcare organization for schools. And I would say one of your strengths is taking programs to scale in India. That's one of your greatest achievements. How are you doing this? What has it taken you, and what are your greatest takeaways, in what you do?
Thank you so much, Mercy, for that. And as the young person on the panel, first of all, I would just like to start by thanking PMNCH and everybody here who's given me this opportunity to be here and to, of course, represent youth-led innovation and the kind of work that I'm doing in my country. And of course, for the 1.8 billion campaign for adolescent health. I feel like for a very long time, this age group was completely neglected, and now that it's being brought to light, I think it's just amazing to see that adolescents and younger people are being focused on a lot more. So before I sort of get into my work, I just want to ask how many people here are parents? Just raise your hands. Okay, I guess most people. And how many of you have a child who's an adolescent right now? Okay, quite few. Or recently was an adolescent. Let me put it that way. Okay, so I'm going to talk a bit about my experience as an adolescent, which actually led me to start my organization, and I think that's extremely important. So I founded Health Set Go Education almost 7 years ago, and it all started from my own lived experience of struggling with my physical and mental health while I was in school. I was born quite overweight in my family, and those of you from India, or even I guess maybe people from Africa would relate to it, that when you're young and you're a bit overweight or a bit chubby, it's looked at very positively in our culture. If you say, oh, that's a very healthy child, actually it's a positive thing to say, like, where you correlate being overweight with being healthy. And, when you grow up like that, it all seems fine. But as I started growing up, I very soon realized that, I was really struggling with my body image. I was struggling with my self-esteem. And I got extremely bullied in school throughout my time. So if you have, if you're parents of adolescent children, or they've gone through that, or you've gone through that time in school where you were bullied, it's a very lost time, for everyone to go through when you don't know about your health. And at that time, I didn't have any support from my home, because I don't think my parents had the time or maybe even the inclination to educate me about how to get healthier or where to look for my mental health. And I didn't have any support in my school, because my school really didn't have anyone I could talk to. And that is something that really inspired me to start the work with Health Set Go Education, because now, after years of working on my health by myself, I know that today I am a much healthier person, but that was because I had to do it alone. And there are a lot of children out there, a lot of adolescents out there who are struggling with their physical and mental health, and they don't have anywhere to go and anywhere to really look forward to doing that. So I personally made it my mission to ensure that every child in India has access to healthcare and health education when they need it. And it was my goal to be preventive, not when there is a problem we try to jump in and try to cure it if we start very early, and that's when the school starts at the age of 2. If we can start then literally talking to children about health, that is when we can create a very long-term change. So today, unfortunately, in India, less than 2% of Indian schools have a health program. In other countries, it's very well recognized that, okay, every school needs to have medical support or a counselor. But in India, it's not like that. And that is where I decided to start my work. And today, HealthSetGo has impacted over 300,000 children. We worked with schools across the country. And in India, a country of 260 million plus children, 300,000 is obviously nothing, but we really hope to reach 5 million children in the next couple of years. That is our personal goal. And what we have done is we've implemented a standardized healthcare program in every school, which is possible to do it at a very low cost. So we do this in approximately $1.50 per child per year. We are able to provide an annual screening program where we have a team of doctors that goes to every school that have a BMI screening. We have a dental checkup, an eye checkup, an ENT assessment, which is actually something that should happen. But most schools don't have that, and parents don't really have the time, as was previously mentioned, to take their children to doctors. So a lot of the things are left unseen, including a lot of conditions that are breeding, a lot of micronutrient deficiencies, etc. They go completely unseen. So this program helps us do that. And in fact, I was talking to someone today and they said in India there does not exist data, health data of this age group between 5 to 17 of their health statistics. So that was very surprising for me to hear, because organizations like mine are actually actively working, and it would be good if the government does work with organizations like ours to scale this kind of work that we're doing. And apart from that, health education is also really important. I know a lot of probably organizations or governments don't exactly invest in health education as much, but it definitely has a very long-term impact on a child's life. So these are the couple of initiatives that we have been taking. And one of the biggest lessons that we learned going through this in the last 7 years, we have collected a lot of information. And what we realized is one of the biggest problems in India was micronutrient deficiency. And now, because young people are kind of synonymous with innovations, we actually started working on our own solution to that. We're actually currently, we've been in the last year working on figuring out how we can get vitamin and mineral supplementation for children. And I'm proud to say that we've launched a new vertical, which is our nutrition vertical, and we've launched a range of vitamin gummies for children. And if you ask urban parents, like I'm sure a lot of parents here, when your kids were young, you all gave them gummies, right? It's something of an urban trend in the US and in other countries, less in India probably and Africa. But, it's something that, why shouldn't it be given to underserved communities and children? Because it's a very happy intervention. And we recently launched it, and we're doing a lot of work in making sure that we've launched it as a product so that every urban person, every urban parent who buys one box of gummies, the proceeds of those gummies actually go to underserved communities, and we definitely want to scale this. So I would say that there's a lot going on with young people. There's a lot that we're trying to do, and sometimes I find that there's a lot of distance between ministers of health and organizations like mine, where I don't know if we're communicating or connecting, or if there is an intergenerational dialogue. I mean, we would love to work and help scale our program with the help of the government or with the help of other nonprofits, but sometimes that opportunity is kind of looked over when it comes to young people. So I would definitely recommend everyone from every country, find maybe grassroots interventions that are doing really well, and do try to work with them and scale them, because, we do need that kind of support and this kind of platform to bring forth what we're doing. And I think that should be encouraged.
Wow. A round of applause for the young lady. Very well done, Priya. Now, if there's anyone here who feels a kind of disconnect, or like there's no communication between either what they're doing and the other person, there are so many people who are represented here, are represented from your organizations, donors, governments. Please, Priya, I would urge you to connect with Honorable Minister after this, and with Martin from IPU, so that we know how to really, clear that disconnect between young people and parliamentarians, because like everybody has said, we cannot work in silos, right? Now, to the last panelist who's sitting next to me, save the last for the one who's sitting next to you. Now, we have talked about humanitarian settings and people in fragile, conditions. And we've talked about Sudan a lot. And I'll use Sudan because it's the most recent, crisis that we are dealing with. When fighting started happening in Sudan, what did everyone do? They brought their people out, mostly the foreigners. And we know that Sudan is one of the countries that has really relied on humanitarian aid, on, medical professionals from outside Sudan, the MSFs and all that. But most of those have been pulled out. I think this is a classic example of why we should really invest in like community health workers, so that we have that care being given to the people, even when when we are in the trenches and we cannot really get the support from elsewhere. How important is it that we really invest in the health workforce and, most importantly, the CHWs to continue providing services to the most vulnerable women and children during such times?
Thank you, Mercy. I want to double down on some of the statistics you gave at the very beginning. 2/3 of maternal deaths and half of newborn deaths and half of stillbirths around the globe are happening in the 29 countries with UN humanitarian appeals in 2023. And it's not just about the magnitude, but it's also about the rate. So if you take a country like South Sudan, neighboring Sudan, 40 per 1,000 is the neonatal mortality rate. So that is 1 in 25 live births ending in a newborn death. That's 1 in 25 moms losing a baby. So we should be outraged. We should be shocked into action, 1 in 25. And the salience of the humanitarian space, the burden of the humanitarian space is only going to get bigger with the shift in climate and what we're starting to see in many places around displacement due to climate or conflict due to climate. And so in these contexts, community health systems are so incredibly valuable. So if you look at protracted crises, context of protracted crises, you see that institutional delivery rates are abysmal. So South Sudan, again, another example, the institutional delivery rate is 20%. And then in an acute crisis like Sudan, you see the utter disruption that is happening in the health system. And so despite that, we're not investing enough in community-based systems. So in stable contexts, we have a lot of evidence that community-based maternal newborn care programs reduce maternal and newborn mortality by 20 to 25%. We have so many exemplar countries like India, Uganda, Nepal, Bangladesh that made huge strides during the MDG era because of community health workers. And so there's a little bit of a gap there in understanding why we have such high mortality rates in these contexts when we know what works, and investment in community health systems are going to be important. It's not very proportional in terms of the burden and the investment that's happening around community health systems. And then in terms of key steps to ensuring community health systems function in times of crisis, so one is preparedness. And so policymakers and governments need to invest in comprehensive preparedness and response plans and recognize that existing community health systems can be utilized during times of crisis. There's also global standard of minimum initial service package for sexual reproductive health in crises. And that global standard includes services that range from community-based to higher levels of facility-based services. And so policymakers and governments need to essentially prepare for those reproductive health services to be available at times of shock and crisis in order to ensure that we are providing life-saving services, because reproductive health needs do not stop when these things happen, as you see in Sudan. Also, another thing that we are investing in as an organization is ensuring that these community health programs are provider-centered and client-centered. So this week, I've heard a lot of language around community health workers and the need to improve trainings, improve supervision, job aids, and that's all fully agreed on. And another thing that we need to keep in mind is the lived experience of the community health workers in these contexts, because they are also the ones that are experiencing the fragility, the conflict, the food insecurity. And so we need to ensure that as these community health workers are deployed in these contexts, that we are caring for the carer and that we're ensuring that they have all the right tools, but also the support that they need to be able to deliver life-saving services in these contexts. And I also want to refer to a phrase I learned during a self-care session earlier today of using lived experience as evidence and expertise. And of course, this also applies to clients as well, that it's not just about the biological pathway of getting the behaviors or the commodities in the hands and of the moms and babies, but we need to make sure that it is demanded, it is respectful, and also that it takes into account sociocultural context, gender, disability, and of course, unique contexts of conflict and crisis and fragility. And so how are we doing that as an organization? We are investing a lot in research and innovation. So one area that we are investing in is trying mathematical modeling exercises to see if we can identify a package of community-based services that account for the real-life constraints, such as the time of training, financial costs for commodity or training or service provision, and whether or not we can move away from the everything but the kitchen sink model and figuring out what is the sweet spot of ensuring that we're not burdening community health workers too much in relation to the effectiveness of the services that we're providing. We're also investing in human-centered design and behavioral insights to ensure that the services that are being available is desirable and conducive to uptake. And finally, with support from FCDO via the Equal Research Consortium, we're also investing in multi-year implementation research because we really need to understand how or how not community health systems are functioning in areas that are fragile. And then also multi-year investment means that if there are shocks, we can also study how those shocks may be influencing community health programs. And to just conclude shortly that if we are serious about universal health coverage, if we're serious about SDG goals, if we are serious about ending preventable deaths, we just need to make sure that our actions and investments are also targeted to the areas with the greatest need.
Thank you very much. Now, I would have loved to go for another round of questions. Like, I would have loved that. But unfortunately, I cannot because of the interest of time. And that's one of the reasons why we have the reception, so that anybody who has questions, anybody who feels like they need a follow-up on any of the interventions mentioned here, then can find any of the panelists in the reception. And I will make sure they stay until the end of the reception. So a round of applause to our wonderful panel. Thank you so much for joining us. Thank you so much. So you can go back to your seats, and I will now move to the closing remarks. And as I invite the next person, the Born Too Soon is probably one of the proudest things I have ever worked on, especially this year. Thank you, sir. And it's born out of, partnership. Like tens of organizations have worked on these. Tens of individuals have worked on the Born Too Soon, and it's just a labor of love I am so proud of. And one of the organizations that have been very instrumental in, helping PMNCH and partners come up with the Born Too Soon report is UNICEF. So I'm really, really honored to welcome Stephen Laura here to the floor to give the closing remarks before he hands over to the beautiful, phenomenal Helga, who will usher in the reception. You're welcome, Stephen.
Yeah, thank you. And I will repeat quite a number of the statistics because I think it's important that we remember them. as they're quite appalling. But colleagues, as we heard rightly throughout the session this evening, we have a silent emergency on our hands. In 2023, where a woman lives and where her child is born can predetermine whether she or her newborn lives or doesn't. And despite dramatic improvements in survival, nutrition, and education over recent decades, today's children face an uncertain future. Climate change, ecological degradation, migration, conflict, inequalities, predatory commercial practices threaten the health and the future of children in every country. Economic development, concerted international action, and political commitment have brought about rapid change. But economic inequalities mean benefits are not shared by all. Stillbirths, and we heard it, are 34 times higher in the lowest income countries compared to the highest income countries. Maternal deaths are 130 times higher in some lower income countries compared to higher income countries. Climate disruption is creating extreme risks from rising sea levels, extreme weather conditions, water and food insecurity, heat stress, emerging infection diseases, and large-scale population migration. By 2030, 2.3 billion people are projected to live in fragile and conflict-affected contexts. And the adverse impact of this on women and children is real, as we heard. In 9 countries facing severe humanitarian crisis, maternal mortality rates are more than double the world average. Children living in fragile and conflict-affected situations are especially vulnerable, with the under 5 mortality rate in 37 countries classified as fragile and conflict-affected is 3 times higher than for any other countries. These facts speak for themselves, and they are too appalling to not repeat the statistics of this evening. Every seven seconds, a woman or baby dies from a preventable disease. 4.5 million maternal and newborn deaths, stillbirths, are occurring each year, nearly 2 times the loss of life as COVID since the start of the pandemic. Of every 10 babies born, 1 is preterm, and every 40 seconds, one of those babies dies. As Martin said, these statistics should shock us into action. Mortality declines have stalled, yet funding has been diverted to other issues. During the COVID-19 pandemic, as we heard, 77% of all sub-Saharan countries reported decreased allocations for maternal and newborn health. Currently, only 12 of the 106 countries reported that their plans are fully financed. As said before, if we maintain this course, we stand to lose more than 30 million more women and babies by 2030. More than half of them in sub-Saharan Africa. In Hans Rosling's book, Factfulness, he wrote, "Do you know I am obsessed with the numbers for the child mortality rate? It's not only because I care about children. This measure takes the temperature of the whole society. And I ask you, what does 4.5 million maternal and newborn deaths and stillbirths occurring each year tell us about the temperature of our society? What does it tell me? That perhaps the biggest killer of all is our collective complacency. Each of us has an obligation to get this agenda back at the top of every country's agenda. Not just because letting women, children, and adolescents die is unconscionable, but because it's the smartest investment a country can make for inclusivity, prosperity, and resilience to whatever may come next, be it the impacts of climate change, upheaval of conflicts, or the next pandemic. The evidence is clear. Early investments in child health, education, and development have benefits that compound throughout the child's lifetime for their future children and society as a whole. Successful societies invest in their children and protect their rights. Let's change the future and the trajectory for babies born too soon and preventable maternal and newborn death and disability and stillbirth. UNICEF thanks the PMNCH and the World Health Organization for bringing us together this evening and looks forward to working with you and all of our committed partners to advance the agenda towards the SDGs and create a healthier and stronger society. Thank you.
Thank you, Stephen. That was really powerful. So partners of change, why are we here? We're here because there's 10 years of not progress on it has plateaued. And this has caused many of our partners to actually update critical data and guidelines and reports. So it's the INAP, EPMM plan of action. There is Born Too Soon, and there is the stillbirth advocacy guidelines. And now we have heard from Anshu that there is the NC Nurturing Care framework. And if Bernadette and Sheila Manji are in the room, I would like you to stand up and maybe take questions, and please feel free to then, all of you, access them, or also Anshu. UNICEF has also been a critical part of that, so please feel. Please, we cannot stand here next year because we have been equipped with all these wonderful reports that are critical, and now we need to take them to heart to implementation. Enough reports, enough guidelines. Now is the time for accelerated implementation. And in this room, there is movers and shakers. So we are in a good position. Dan Irwin, Toyin, Martin, there are so many here that are critical. UNICEF, WHO, UNFPA, FIGO, IPA, COIN, as well as ICN and ICM. Please reach out to each other and stand together in order to then really accelerate, not only progress, but accelerate. And that is, I think, really critical. As you know, there is nothing called a free lunch, and similarly, nothing called a free reception. Although I must say, we don't treat you very well, we won't feed you that much. But please use each other in order to partner and see how you can get help in implementing and accelerating. Member states, please feel free to reach out to the UN and also other partners in seeing how you can update your key strategies. Please make sure that the resolution that Anshu was talking about makes explicit stillbirth, makes explicit adolescent, and makes explicit that that really becomes a reality. Because, as Mercy and all of you know, that if it does not get counted, it does not count. And it becomes an invisible tragedy, and a terrible death. And that we cannot let. This is happening on our watch. And we are standing here as champions and cannot let this happen. So please use us in PMSH, you are partners, we are here to service you, and use each other in order to then report on a little progress and the right way next year. So please use the reception to partner. Thank you so much. Thank you, Mercy.
You are all free to join the reception. Thank you so much. Thank you so much. And to those who joined us online, thank you so much.